Good afternoon, everybody, and thank you, Dr. Bhalla. So we start with now, what is ocular perfusion pressure? Now, principal theories for pathogenesis of glaucomatous optic neuropathy are mechanical, vascular, and biochemical. However, the existence of normotensive glaucoma cannot be explained by a pressure theory alone, and reducing intraocular pressure is not 100% effective in halting the progression of the disease. Now, the vascular etiology for pathogenesis of glaucoma attempts to explain on the basis of a reduced ocular perfusion pressure, faulty vascular autoregulation, and loss of neurovascular coupling. In 1970, Harry defined glaucoma as a disease wherein the normal balance between intraocular pressure and blood pressure in the choroidal vessels supplying the optic disc and retrolaminar part of the optic nerve is disturbed. This results in a vascular insufficiency, hence in visual field defects and pathological changes in the optic disc and optic nerve. So vascular concept is supported by association of the glaucomatous optic neuropathy with arterial hypertension, oblique hypotension, cardiovascular disease, migraine, vasospasm, and other circulatory disorders. Tissue perfusion means circulation of fluid through the vascular bed of the tissue to supply nutrients and oxygen. And perfusion pressure is the gradient between arterial pressure and venous pressure in the vascular bed, which is responsible for the perfusion. Ocular perfusion pressure is defined or refers to the pressure available to drive blood through the intraocular vasculature, the degree of perfusion being influenced by resistance to flow, which is a function of the vessel caliber or vessel tone. The pressure gradient from an arterial input to venous output, the resistance imparted by fluid composition and vascular geometry determine blood flow through a vessel or ocular tissue. So in general terms, perfusion pressure of an organ is defined as the difference between its arterial and venous blood supply. In the retinal circulation, the pressure gradient begins with the central retinal artery, ending with the central retinal vein and the vortex veins. So the AV pressure gradient or ocular perfusion pressure is equal to difference between the pressure in central retinal artery and central retinal vein. In the eye, the venous pressure roughly equals the IOP, so OPP is arterial pressure minus the intraocular pressure. Now, to prevent the retinal veins from collapsing under the transmural force which is exerted by the intraocular pressure, the pressure inside the central retinal vein should exceed the intraocular pressure. Because of this equilibrium, the IOP closely approximates the pressure inside the central retinal vein, and venous wall transmural pressure is approximately 0 millimeters of mercury at the surface of the disc, justifying the use of IOP as a surrogate for retinal venous pressure. The central retinal artery pressure has been measured by ophthalmodynamometry, but because of the inconvenience of ophthalmodynamometry, the central retinal artery pressure is estimated based on the mean brachial artery blood pressure, that is 2/3 of the mean arterial pressure, which is equivalent to diastolic blood pressure plus 1/3 systolic blood pressure minus the diastolic blood pressure, as we can see here. Hence, OPP to date relies mostly on indirect methods of brachial artery blood pressure and intraocular pressure. Now, OPP can be defined as mean ocular perfusion pressure, systolic ocular perfusion pressure, and diastolic ocular perfusion pressure. So therefore, to re-emphasize, mean ocular perfusion pressure can be calculated using this formula, that is 2/3 of the mean arterial pressure minus intraocular pressure, where mean arterial pressure is diastolic blood pressure, 1/3 systolic blood pressure minus diastolic blood pressure. This 2/3 accounts for the drop in blood pressure between brachial and ophthalmic artery when subject is seated and orbital arteries are further downstream. Systolic ocular perfusion pressure is systemic systolic BP minus IOP, and diastolic ocular perfusion pressure is systemic diastolic blood pressure minus IOP, and this DOPP is especially useful in displaying the lowest ocular perfusion pressure values. So good perfusion would depend on a complex regulation process that balances blood pressure and intraocular pressure. Several studies have suggested association between vascular factors and glaucoma. So hyperperfusion of the optic nerve head could contribute to the glaucomatous damage. Of several studies implicating vascular risk factors in glaucoma, blood pressure and ocular perfusion pressure are the most studied. Now, brachial artery pressure is considered representative of the systemic blood pressure, which is used as the basis for calculation of OPP. However, brachial artery pressure is not a precise predictor of the ophthalmic artery pressures. Now, because of hydrostatic and hydrodynamic postural changes affects both the blood pressure and IOP. So, when we are sitting or standing position, the ocular arterial pressure is lower than the brachial pressure because of flow of resistance of vessels and the hydrostatic pressure column because of the higher head position. So, it is reasonable to assume that in a supine position, there's a different interaction between orbital venous pressure and the intraocular venous pressure. Higher readings of intraocular pressure are often found in the supine position, probably as a result of increase in the episcleral venous pressure. So despite its limitation, OPP is usually approximated in epidemiological studies as the difference of arterial blood pressure and intraocular pressure in the upright position. Postural change can also influence OPP, like when moving from a supine to upright position, the blood pressure drops by 20 to 30 millimeters of mercury in the region of the head. So clinical studies should specify the body position during blood pressure and OPP measurements. Now, depending on body position, different correction factors have been used to account for the difference between brachial and ocular blood pressure. For humans in a seated position, 2/3 is a commonly accepted correction to estimate CRA pressure based on brachial blood pressure. However, literature review of articles on MOP reveals that several papers have erroneously used or reported the formula as MOPP 2/3 of MAP minus IOP in bracket. Now, this resulted in overestimation in the range of 5 to 25%. So the correct formula is 2/3 of mean arterial pressure within bracket minus IOP. Therefore, to ensure uniformity and compatibility between studies, care should be taken to use and report the correct formula when estimating MOPP based on mean arterial pressures and IOP. Now, role of IOP as a risk factor for development and progression of glaucomatous damage is well established. However, OPP includes IOP. It is possible that some of the findings attributed to OPP are in fact secondary to IOP. So it's important to check whether results of study were adjusted for intraocular pressure, anti-glaucoma, and antihypertensive medication. There's a strong association of open-angle glaucoma prevalence with low ocular perfusion pressure, low diastolic blood pressure less than 60, and high systolic blood pressures more than 170. So both extremes of BP spectrum are at greater risk of glaucoma. Now, low diastolic blood pressure, the patients suffer from low ocular perfusion pressure at the optic nerve head, and with high systolic blood pressure, it leads to decrease in vessel diameter, leading to arteriosclerosis, compromising vascular autoregulation, and impairing nutrient exchange in the capillary bed. So this hypothesis indicates that low ocular perfusion pressures can occur secondary to high IOP, low or high BP, and arteriosclerosis. So although clinicians have known for decades that IOP varies throughout the 24-hour period, only recently have circadian pattern being detected for other factors that influence ocular health, such as systemic blood pressure, ocular perfusion pressure, and ocular blood flow. Now, systolic and diastolic blood pressures decline or dips during sleep between 2 and 4 a.m. due to decrease in the sympathetic system activity during sleep. Nocturnal physiological dipping is seen in 2/3 of healthy individuals, where systolic blood pressure decreases by 10 to 12% and diastolic by 14 to 17%. We can classify them as non-dippers if nocturnal decline is absent or blunted, and extreme dippers if the fall is greater than 15 to 20%. Excessive dipping is associated with development and progression of glaucoma. It is also suggested that lack of physiological dip may be harmful and may result in impaired microcirculation associated with excessive free radical production, toxic to neurons or glial cells. Now, reduction in both OPP and ocular blood flow occurs during sleep due to combined effect of rise in intraocular pressure and dip of systemic blood pressure. There are significantly lower diastolic blood pressure at 4 a.m. and lower DOPPs in POAG patients during whole night from midnight to 6 a.m. So low nocturnal ocular perfusion pressure might result in further damage in glaucoma patients, especially when autoregulation is impaired. Circadian MOPP flow may be the most important risk factor for glaucoma, in addition to being important in NTG with nocturnal hypertension, and may have a role in development regardless of nocturnal hypertension. Now, free radicals derived from ischemia and reperfusion may contribute to reversible, irreversible manifestations of cell injury. It is hypothesized that chronic, repetitive, circadian, ocular blood flow variations could result in accumulative ischemia and reperfusion manifesting in the form of RNFL damage and visual field deterioration. Now, understanding circadian variation in OPP is important for assessing the risk of glaucoma progression. Hence, the importance of a 24-hour monitoring of blood pressure and IOP simultaneously. Wider circadian OPP fluctuations were associated with worse visual defects, and Choi et al. Identified circadian OPP fluctuation as the most consistent risk factor for glaucoma severity. Now, blood flow is autoregulated to maintain a constant flow despite fluctuations in perfusion pressure, and this causes local vascular constriction or dilatation, maintaining a constant nutrient supply in response to perfusion pressure changes. Vascular dysregulation is hypothesized to be involved in at least some cases of glaucoma, especially in normotensive glaucoma. And selective dysfunction of vascular endothelium with associated defects in release of endothelium-derived vasodilators is thought to contribute to vasospasm. So this could lead not only to a chronically low perfusion, but unstable perfusion with wide fluctuations. In autoregulated vascular bed, these changes do not translate into change in blood flow, but in non-autoregulated vascular bed, these changes may lead to changes in the blood flow. So low systemic blood pressures combined with elevated IOP will reduce OPP at the optic nerve head, reducing blood flow in eyes with impaired autoregulatory system. Even in the presence of autoregulation, low OPP predisposes for ischemic periods by reducing the range of autoregulatory reserve. Abnormal autoregulation in response to acute changes in OPP in glaucoma patients may occur, say, example, after change in body position, any increase in IOP, or reduction in the blood pressure. So unstable OPP rather than steady reduction in ocular blood flow may contribute to the process of glaucomatous optic neuropathy. The American Heart Association recommends aggressive control of blood pressure in patients with CAD risk and LVD dysfunction. However, aggressive treatment of systemic hypertension was deleterious for glaucoma patients, and over-treatment of systemic hypertension could worsen glaucoma. So besides contribution of low blood pressure to glaucoma risk, the compromised vascular system has the inability of the eye to maintain consistent and adequate perfusion during the pharmacologically lowered blood pressure. And low diastolic blood pressures due to antihypertensive therapy were associated with increased cupping. So to summarize, ocular perfusion pressure as a risk factor for development and progression of glaucoma is an important current topic in glaucoma research. A balance between intraocular pressure and blood pressure influenced by the autoregulatory mechanism is partly what determines if an individual will develop optic nerve damage. So the importance of a relevant clinical history, 24-hour blood pressure and IOP monitoring were indicated, identifying and treating systemic factors which could contribute to development and worsening of glaucomatous optic neuropathy. Despite limitations on reliability in measuring ocular perfusion pressure, there's continued interest in measurement of this parameter and potential therapeutic intervention in patients with documented low ocular perfusion pressure and continued disease progression. So ultimately, we must use this facet of pathogenesis in better management of our patients suffering from this condition in a more holistic manner. Thank you.